Hello, everyone, and welcome to today's webinar. Good morning, good afternoon, good evening, depending on where you are in the world. Thank you for joining today's webinar. Today, we are going to speak on neonatal HFOV ventilators, and with us, we have the esteemed Professor Daniele De Luca, who comes to us from France, where he is the chief of the Division of Pediatrics and Neonatal Critical Care at the Paris-Saclay University Hospitals. And he is also president of the European Society of Pediatric and Neonatal Intensive Care. So Daniele, thank you very much for your time today, for being with us today. We look forward for the lecture. If there are any questions, we will run a approximately 10-minute Q&A session at the end. So make sure to input your question in the Q&A section, and we will do our best to have Daniele answer it. Daniele, I think you can now share your slides, and the floor is all yours.
Thank you. Thank you very much, Maya, and thank you everyone for being here. I think you see my slides, and it's a pleasure to be here, and I hope that this is going to be only the first one of a long series. So today I'm gonna speak about something that is a little bit particular, because we're gonna compare, at least in terms of some items, different ventilators providing HFOV for neonates. And you know, I wanted to tell you that since the beginning that not all ventilators are created equal. Actually, this is a new concept, although probably it's something that you have been already hearing, particularly before the COVID era, because we started to do some hands-on comparison in different congresses. And now we start to have quite a bunch of data telling us a little bit more about the different performances of the different neonatal ventilators. So I will go over the available data that have been already published, and then I'll show you some of my personal data that have been produced in my lab, in my NICU at Paris-Saclay University, whose have been just accepted for publication in respiratory care a few weeks ago, and will be available on the PubMed very, very soon. Yeah, as you probably know, otherwise I'll tell you, there are many ventilators providing HFOV right now. And whatever may be your idea about HFOV, I think that everyone agrees that this is a technique that is really, really important for neonatal critical care. It's probably not a miracle, but every one of us has used HFOV in a situation where no other technique would have been useful, as a sort of an early rescue. That should be the best strategy. But anyway, as a rescue for babies with the most severe respiratory failure. And that's also a strategy that has been recognized to be more useful in terms of reduction of mortality and bronchopulmonary dysplasia, at least according to the Cochrane meta-analysis 2015 and the individual patient meta-analysis published by Philip Coles in Lancet 2010. So here you see all the ventilators, at least those that I'm aware of, providing HFOV. But make no mistake, each of them has different technical characteristics, and some of them have different even waveforms and even different technology to produce the oscillation. Obviously, we can understand that this is going to have an impact on the performances of the ventilator. So the two meta-analyses that I just mentioned, that I clearly say that it's not a technology that is actually impacting mortality or BPD, but anyway, we know that you must know what is the technology and what is the performance in order to use at the best the machine and optimize the oscillatory boundaries in order to get the right ventilation, oxygenation, and eventually influence the outcomes. So the idea to compare ventilators is not actually new. As you may see here from this very almost old paper from an Italian journal, you see there were even very old ventilators that are not even on the market, like the BO ones. And you can clearly see that that there is a difference in terms of delta P provided comparing these ventilators. But now we have new ventilators, what I would like to call like second generation oscillators, because they are ventilators with a sort of a electronic control of what is provided, huge screen. You can even have a monitoring of your stroke volume in high frequency. And there are several characteristics that were not available at the time of sensor medics, which is supposed to be the gold standard for high frequency. And before myself and before my group, others have actually compared the performances of these ventilators. For example, you see here from the Raffaele Della Cas group, this is a comparison in terms of a delta P variation measured at the endotracheal tube in terms of varying frequencies. So you can clearly see the different ventilators have different performances, and some of them are even worrisome because you can clearly see the dragger going very up with a very large variation. Same applies for the SLE. Fabian is very much steady, is very much stable, and it's clearly probably the most similar to the Sensormedics, which I still think to be sort of a gold standard, although obviously it's an old machine and there is no electronic control of volume when you use it. This other paper is coming from David Tingay from Melbourne, my good friend, has been the first one demonstrating that the new, relatively new dragger machine, the VN500, is actually unable to provide a constant amplitude at the ventilator here on the left or on the endotracheal tube while increasing the frequency. You see this the gold standard is again the same ventilator, you know, with a flat line, but the performance of the VN500 is very much decreasing over increasing frequency. And this is something that has been described for the very first time in 1997 with the old Babylog, which actually shares the same technology with VN500. So that's a ventilator with a flow interruption by the cyclic oscillation of the PEEP valve, capable to introduce an oscillation in the gas flow in the circuit. So not actually a true oscillator with an active oscillatory phase. Then again, David compared many oscillators, second generation oscillators, so second generation ventilators, providing again similar results. You see here, for example, the delta P on the y-axis that is provided by the ventilator compared to the delta P that is set on the machine is very much steady and correlate for most of these ventilators, which is not the case for VN500 because it's a sort of a plateau, and same applies for Sophie, for example, not to mention the old Babylog that you can clearly see provides even lower delta P. And you know the delta P is something that is very much important because it's the main boundary responsible for the production of the volume, of the stroke volume delivered to the baby, which I don't call tidal volume because we're not providing a tidal ventilation, but still is the small volume that is provided by the cyclic oscillation towards the baby. So then Peter Rimmersberger's group, former ESPNIC president Peter, did a very nice experiment looking at the data the other way around. So they look directly at the volume. They call it tidal volume, and as I told you, I do prefer to call it stroke volume. And they looked at the volume, and again, they found consistent data because you see, for example, here in blue, again, that's the Babylog machine. So to be honest, they call it Babylog, but it's the VN500, so the new sort of a new Babylog from Drager. Again, you see there is a sort of a plateau in terms of volume provided, and sometimes the machine is not even able to reach 60 centimeters of pressure amplitude, so it's very much limited. And anyway, also in other settings, as you see here, the volume that is provided is lower compared to the other ventilation, compared to the other ventilators. And this is very much resumed by these tables here that are actually giving you the data behind the graphs that I just showed you. And it's interesting to see that the performance is even lower, mostly for all ventilators, when there is an increment in the resistance in the ventilatory circuit. So when we're trying to ventilate the sickest patients, and I will go over that more in detail later. But then the same group trying to analyze the performances of these ventilators when they use the volume guarantee modality. And this is obviously a new modality that was not available at the time of Sensormedics. So basically, you have a target volume that you want to achieve and give to the baby. And then you say to the ventilator, okay, you're going to adjust your delta P, your amplitude, in order to provide always the same stroke volume. So it's something pretty much similar to what is happening in volume guarantee in conventional ventilation. But again, you can clearly see, for example, that the VN500 has a very widely variable performance, and we cannot actually say that the volume that was wished to be given to the baby, so 4 ml, was actually maintained, because you see how much is variable. And Leonie is more or less the same. And the Fabian has a good performance, because you see that more or less is always steady around 4 ml, and anyway is less far from the target compared to the other ventilators. So some years ago, together with Raffaele, we did a nice experiment, because we tested the accuracy of volume delivery and also pressure delivery for several ventilators in my NICU, in my lab, and in other NICUs across Europe. To be honest, these tests were done in conventional ventilation, but we have no reason to believe that these ventilators are going to perform differently. And the reason is that at the end of the day, the findings suggest that there is a loss of accuracy in ventilation variables, and this is more or less related to the daily use and how can I say, the control that are undergoing, that they've been undergoing by the hospital during the use of the machine. So we have to take care of our machines. The maintenance and the controls that we may want to do and we can do during the use is very much important, as much as it is important the design that actually provided the differences that I just mentioned in the previous studies. So this is also coming to another aspect, again highlighted by the Peters group, which is the increase in workup briefing. So since our patients are rarely paralyzed, or anyway deeply sedated, there may be an increment in workup briefing if the ventilator is not really good. And in fact, there is an increment in terms of workup briefing when you see, when you compare, for example, the Fabian here, that's the VN500, and that's the Leonie. And again, there are some settings that are not even achievable by the VN500. So here we come. We had a look at all these bunch of data, and we realized that actually those are very much interesting, but we needed an additional study to understand actually what is the performance in terms of pressure delivery variation when it comes to babies with different lung mechanics characteristics. And this is because all the studies that I mentioned so far were focusing on babies, dividing them in like preterm babies or full-term babies, or even infants, which obviously means the need for a higher energy, higher power to ventilate the bigger babies. But there was no clear distinction between patients with a normal lung or a restrictive lung, like for example, babies with RDS, which is the most common condition that is being ventilated, or even neonatal ARDS, so a little bit more severe condition, or mixed one, like the infants that just recovered by RDS, but are going to develop bronchopulmonary dysplasia, which is a mixed and dishomogeneous condition associated with both reduced compliance and increased airway resistances. So we focused on that, and we created a benchtop in vitro physiological model to study this on many, many second-generation oscillations. And the hypothesis was that the oscillation transmission would significantly vary between the different brands, but also according to the different lung mechanics condition. So here you see we actually tested the VN500, the Fabian HFO, the Leonie Plus, and the SLE 5000. And you can clearly see that the technical characteristics are very much different. Even the oscillation amplitude range that the manufacturers claim to provide are widely variable. And then you will see in a second, the results are even widely variable, and these ranges are not actually achieved by the machines as the manufacturers tell us. And we, again, took as a reference the good Vyaire Sensormedics 300A, which is the typical model for neonates. That's our model. It's nothing very new. We use the Florian respiratory monitor that has been validated many, many years ago by Jan Pillo's group on high frequency measurements. That's the one that we already use in our lab for other studies you may be aware of, particularly those on non-invasive high frequency ventilation. So nothing really new, and the paper has been just published in the Respiratory Care And you will find it with the first name, Roberta Centorino, my fellow, who did all the job. So the setting was reproducing these three types of babies. So the first one was a no lung disease baby, so a baby that actually does not need to be ventilated in high frequency oscillation, but we use it as an internal comparison. A baby with a restrictive condition, so reduced compliance and pretty normal resistances, and a baby, as I told you, we develop in BPD with a reduced compliance, but also very much increased by a factor of 5 airway resistances. So here you see the difference in terms of mean airway pressure delivered at the lung model. The first thing you would like to notice is that Fabian is always providing the pressure that we claimed for, even a little bit more than what we actually claimed. While all the other ventilators have a variability in this sense, and some of them are similar to Fabian, some other a little bit less. But the most important thing is to be focused on the oscillation pressure. So the oscillation transmission rather than the simple steady mean airway pressure transmission. So in order to understand the oscillation transmission, and so to measure it, we are going to use a parameter that is called OPR, meaning oscillatory pressure ratio. That's a classical parameter in HFO mechanics. It's been published like 25 years ago for the first time, and is calculated as the ratio between the oscillatory pressure measuring at the given level, for example, at our lung model, in our case, divided by the oscillation that has been set on the ventilator. So meaning the OPR is giving you the idea of a portion, the fraction of the oscillation that is actually transmitted downstream compared to the oscillation that you asked the machine to provide. Because, you know, this can be reduced by the compliance of the tubings and the model in this case, and the airways and the lung. And this is exactly why we needed to compare lungs with different conditions, like the one with a normal compliance, the restrictive one with decreased compliance, and the mixed one with reduced compliance and increased resistances. So you can clearly see here that there is a huge difference between the ventilators. Fabian is in blue and is performing pretty well, particularly on restrictive and mixed condition. The VM500 is also performing well in these two conditions, and this is something that has not been noticed in other studies, because here we are looking at the transmission overall, you know, mixing a bunch of different possible parameter interactions, while in other studies they only measured the tidal volume or the oscillatory pressure at the given point with some particular parameter combinations, and we knew that the VN was not able to achieve the strongest, the more aggressive parameter combination. But here we are giving a full bunch of data, and we are investigating the ventilator performance on a full bunch of parameters. So sort of a very much pragmatic real-life test, taking into consideration all the parameters that you may want to use at bedside. And those are the raw data behind the graph that I just showed you. And you can clearly see that all the differences in terms of APR are more or less all statistically significant. Then we did some sub-analysis per changing amplitude and per changing frequency protocols. That's very much important because amplitude and frequencies are the two parameters that are impacting on the oscillator transmission and so on the OPR. Amplitude is the first one because, you know, we're used to change amplitude as a first step, and it's also the parameter that is going to have the biggest impact on the transmission. And you can clearly see here on the x-axis the OPR, so the oscillatory pressure ratio. And you see that one thing is sure, the Fabian and the VN, again, outweighed all the other ventilators in terms of oscillation delivery. But if you consider the mean that is depicted by the bar here, the line in the middle, and the standard deviation of this data. So if you consider the coefficient of variation, which is the standard deviation divided the mean, which is giving you an idea of the data variability, well, you will see that there is a quite wide variability, and the Fabian is performing particularly well in terms of narrow variability, which is something very important for safety, because we want to be more or less sure that what we are asking to a machine is actually provided to our patient. Those are the raw data. behind the graph. Again, almost all significantly, almost all significant in terms of differences between the various ventilators and the models. And then again, the data coming from the changing frequency protocol sub-analysis. And it's very much the same, as you can clearly see. And also the raw data are very much similar to those produced by the sub-analysis per changing amplitude protocol. So then, if we put all together all this data, which is something we actually did, and place them in a multivariate regression model. So let's say a multivariable regression in order to understand what are the factors that are more significantly and more importantly influencing our outcome, which is the oscillation delivery. You will see the two ventilators with the best oscillation delivery, so the higher oscillation transmission, are again, as I told you, the Fabian and the VN500, but also that the type of device accounts for 36% of oscillation delivery. So it means that if you choose the right device, you have more than 1/3 of the, let's say, possibility to have a higher oscillation delivery. The mechanical pattern of the lung being ventilated is accounting for 20%. So it's important, but it's less important than the machine. So you gotta know what is your machine, choose the right machine, use it at the best in terms of mechanical parameters. Also taking into consideration the very nice data produced by the other groups before us, and I already showed you, in order to have the maximum of likelihood to provide a good oscillation transmission to your patients. So as a take-home message, I will tell you that the oscillation transmission is more dependent on the ventilator model than on the mechanical condition of the lung being ventilated, although this must be considered, obviously at equal HFOV parameters. And you gotta know what are the boundaries to be or to be preferred or that can be used in each machine according to the data coming from the other studies that I showed you. You gotta know that Fabian HFO and VN500 provide the greater transmission overall, and the Fabian HFO has the lowest variability, so the more steady oscillation transmission when you are increasing amplitude, which is something that we do at the bedside every day. We still have open questions regarding the ventilator comparison. For example, we're now studying the ventilator noise, and hopefully we will come out with some data about that very soon. And another very important question would be what type of tubings we should use, because this data has been produced always with the same tubings. The standard one, I don't want to do any advertisement, but the standard one from a very known company using that. But other data have been produced by changing the ventilatory tubings, using also the tubings that are suggested by each ventilator producer. And that could be also a nice strategy, but this is to be discussed, and we do not have any data to prefer one strategy or the other. So I thank you very much for your attention, and also taking the occasion to invite you by the end of May to my Congress in Paris, the 4th launch. You know, that's the only and unique Congress exclusively dedicated to lung ultrasound in neonates and children in NICU and PICU. We're going to have 3 days, 1 day exclusively dedicated to hands-on sessions, and 2 days of a very beautiful scientific communication by all the key opinion leaders in the technique from all over the world, and also free communication and abstracts from your side. Participation is going to be possible either face-to-face and also virtual, and I'm more than happy to host you. Thank you very much for your attention, and I'm happy to take your question or to connect with you by email, as you may see here. Thanks again.
Thank you, Daniele. This is great. We're going to have a good session of Q&A. So if you have any questions, obviously, please don't hesitate to pop them up in the Q&A section. We do have 2 questions already. Daniele, the first one is, so thank you for the great presentation. What type of circuits were used? So I think this echoes what you were saying at the end. What type of circuits were used in OPR analysis with the different ventilators? Were all manufacturer calibrating oscillators before the trial? And where do you see differences between Accutronics, so the Fabian and the Leone ventilators?
If I get it correctly, we use the Fisher and Paykel standard circuit that is actually very suitable for every ventilator. So there is no difference in terms of tubing compliance or stiffness anyway, because we use the same for everyone. So the difference is that I showed you, particularly between the ventilators that you mentioned, can only be due to the ventilators and not to the circuit. Then the question is better to use this tubing, this circuit, or any other? That's a good question, and I cannot answer that.
Thank you, Daniele. Another question is, do you recommend making it common of practice use to use volume guarantee on the VN500?
That's a very difficult question, because I take it as do you recommend to use volume guarantee at all? I mean, in VN500 or in any other. I think that it's a nice add-on, although at least in my NICU, we do not use the volume guarantee in high frequency on a day-by-day basis, not so commonly, let's say. In general, I think that particularly if you do not have enough personnel, you have a lot of beds, everything that can be servo-controlled somehow, it's obviously very nice. Let's think about the oxygen servo-control, that's very much important. But then you must be very much aware of the physiological significance of volume guarantee in high frequency, and how to manage the boundaries in this modality, because they're not going to be exactly the same like in any high frequency without volume guarantee. So be sure about how to use the parameters and what is their significance.
Thanks, Daniele. Another question is, have you had the opportunity to assess each of the platforms for nasal HFOV?
No, thank you very much. That's a very good question. We should go over it. We have the possibility in my lab to do that. And we'll certainly do that. The problem is always the same. We need more fellow to do that.
Okay, the next question is, so great talk, lots of interesting data, thank you. But regarding the clinical relevance, can I compensate the disadvantage of not such a good ventilator, but by just dialing up the numbers? Does it matter just going by the clinical effect?
I think that's a little bit riskful strategy. First of all, because as you notice, some ventilators are not even able to provide a very high delta P oscillation. Then obviously our patients are carefully monitored. So you're gonna know the oxygenation, you're gonna know the CO2 and the gas exchange. But sometimes I think it's an experience of every one of us. Sometimes you can clearly notice that you cannot achieve the gas exchange goal that you wish with a given machine, particularly for the more severe patients or the biggest ones. So I can hardly think that you can compensate everything for everyone.
Thanks, Daniele. Another question is, how can we measure the target volume through HFOV? Tidal volume, sorry, through HFOV.
Yeah, well, anyway, tidal volume or stroke volume. But this is easily done by all the new second generation oscillators, because they have a flow sensor, which is a hot wire anemometer, which is placed on the Y piece, very close to the endotracheal tube. And so it's able to measure the volume over there exactly the same way they do for conventional ventilation. The thing is that the software has been, calibrated to measure even such as very small and oscillating volumes.
Thank you, Daniele. The question is about the comparative data between the Fabian and the Stefan Sophie. Do we have, or why don't we have data?
Yes, there are some data from the Peter Rimmersberger's group, as I showed you. And the Sophie actually is doing sort of a plateau, a little bit better, but very much similar to what has been showed for the IN500. So after a given, level of oscillation, is no more able to increase the actually transmitted oscillation and to increase the volume delivered to the baby.
How would you explain that? Is that a ventilator characteristic, or is there a specific reason for that?
That's a ventilator characteristics for sure, exactly like for all the others. Then the question is that more related to the fact that some of these ventilators are not real oscillators because they do not provide the active oscillatory phase? Or is that more linked to the different waveforms because they have also different waveforms? I don't know, but surely all these ventilators provide HFOV with a different technical traits, and those are responsible for the performances.
Thank you, Daniele. A question for you. Is it possible to use the Fabian ventilator during neonatal transport?
Oh yeah, we do that all the time. We have in my ambulances, we have two beautiful Fabian HFO, and we're very happy about that.
Okay. Another question with regards to babies with different weight and different conditions. Will or are the outcomes different with different ventilators? Do you see something like that happening?
The only thing you gotta know about the weight is that there are some ventilators, those that we just mentioned, that are not very much suitable to ventilate in high frequency a term baby. So a baby even, you know, above 2 kilos. Clearly because this would require a higher energy that these ventilators, because of their technical characteristics, are not able to provide. It's nothing new. It was the same at the time of Baby Log 8000 back in those days. And you can clearly recognize that because the baby is not well ventilated and you have to change the machine. That's exactly why I said before that I can hardly believe that everything can be adjusted for everyone. I was particularly referring to these bigger babies.
Okay. There's a question about the SLEs. So is the SLE 6000 equal to the 5000 in transmission, or is the newer version doing better?
I cannot answer this question. We didn't test this particular ventilator.
Okay. What is the best ventilator in delivering the appropriate tidal volume for babies, especially in volume guarantee? From your perspective.
We didn't test the volume guarantee, as you know, but if you have a look at the Peter Riemensberger's group data, I would say that Fabian is performing better on overall because it's more, you know, it's closer to the target volume on average, taking all the parameters into consideration, while the others have a quite variable performance.
Okay, thank you. There's a question about closed loop oxygen control and the fact that not all the platforms and ventilators out there feature it. How important do you see this going forward and in 2022?
Well, that's a good question. The oxygen control, the automated oxygen control has been out for quite a long time, you know, since the first experiment by Eduardo Bancalari in Miami many years ago. And if we're waiting for a clear hard evidence, like in pharmacological trials, I think we're going to wait for quite a long time. And it also depends on what are you going to ask to the technique. If you ask the technique to be a miracle and to avoid bronchopulmonary dysplasia, well, probably ask twice, you know, that's probably not the job for the technique. But if you are asking the technique to reduce the oxygen exposure with all the consequences, for example, in terms of ROP, or anyway, in terms of oxygenation, and if you are asking the technique to personalize better the ventilatory care, particularly when we do not have enough personnel, and I guess we're never going to have enough personnel, I personally think that the oxygen controller, like the volume guarantee, are a useful add-on to our ventilators.
Thank you, Daniele. We have a question, or maybe there's an ask for you to share your experience with nasal HFOV. Can you speak to us a little bit on that?
Oh yeah, that will require completely a dedicated webinar, because you know that I'm in love with nasal HFO, and we can eventually do that in another webinar. But basically, this is our rescue strategy that we provide with Fabian for those babies developing BPD, and so going to be affected by a chronic respiratory failure, that you actually don't want to reintubate again, because otherwise you know that this is going to be a hell of a mess. And so the nasal high frequency represents sort of a last resource before the reintubation, and it works. It works pretty well in the majority of cases. So you probably may have a look at our review that has been just recently published in the Clinics of Perinatology, with all the data from, meta-analyzed from the trials on nasal HFO available so far. And also we provide our protocol and our flow chart to use nasal HFO in that paper. First author is always Dr. Santorino, and I'm the second one. So take a look at that, and probably let's talk about that on the next webinar.
Thank you, Daniele. There are a few questions on really the difference between the modern ventilators. So one of them is about the power of the ventilator. Do you recommend any evidence and studies? And I think you touched on this a little bit during your presentation, but any evidence to say that one modern ventilator would be more powerful than another, or would potentially have better outcomes if you're using it?
In terms of power, from the data that I showed you what are the ventilators that do not provide enough power, at least for bigger babies. And that may also be interesting for those of you that are in a mixed PICU NICU ward, because you may want to ventilate in high frequency also infants beyond the neonatal age. Then I don't know if I get it correctly, but that's the most important thing to be kept in mind. And then obviously the second one is to use correctly the ventilator, using the best of the parameters that particular device can achieve.
And so given the fact that modern ventilators work on different principles, right? Is one better than the other, or is there a difference when you look at the physiological principle?
For sure, there is some that are better than the others, as I told you. Difficult to say what is the particular technical traits that makes that ventilator better on another. And then it's a matter of monitoring your patients and try to understand, particularly for bigger babies, if you need to change the ventilator because you're not ventilating it right.
All right. A question about, again, coming back to weight group, and I'm sorry, I'm trying to read through all the questions. We have over 20 questions in the Q&A right now.
I have time.
Can you recommend which weight group HFOV has a good outcome on, having similar pathologies, of course?
That's a very important and old question. We have been dealing with that for many, many years, even decades. So right now we know that it's not a matter of weight or age group. It's mostly a matter of time and mindset. The Cochrane meta-analysis 2015 and the Lancet one 2010 clearly demonstrated that with a lot of data. If you apply HFO early as a rescue, meaning in the first 4 or 5 hours of the beginning of respiratory failure, you're going to reduce BPD and mortality by more or less 20%. If you get there too late, HFOV is not going to be a miracle, not even with Fabian or any other device. So it's important to act quickly, and it's obviously important to use it correctly. You got to be, well-versed in order to choose the right parameter and manage HFOV correctly.
All right. Another question. Before the question, the attendee is thanking you for the wonderful presentation. Do you think that using a specific circuit, something perhaps more stiff, in Fabian ventilators could improve the OPR?
Theoretically, we know that, the stiffer is a structure, the better is the oscillation transmission. That's something we know since quite a long time. Then what is the actual effect on that, on Fabian or other ventilators, must be studied. So I cannot provide a clear advice on that.
Okay. You shared that the Sensormedics is the ancestor, basically, of the different ventilators. Since it's being obviously dismarketed and the manufacturing of it has stopped, given your lecture, what would you recommend as an ideal replacement for the Sensormedics?
Oh, that's a personal opinion. I can clearly tell you that I do recommend Fabian, and at least this is something that we choose in my unit. And so this is what we use, absolutely.
Okay. There's a question on the VN500. During the daily use of a VN500, it is observed that it's possible to get a good decrease of CO2, decreasing frequency to 9 or 7 hertz. What do we think about these frequency settings on a premature infant?
Well, that's a very important question. Obviously, when you go down with the frequency, you're going to have the effect that you just mentioned, but you must be very careful, because by doing that, you are increasing quite a lot the energy that is delivered to the airways and so to the lung, particularly in smaller babies when, VN can be used because it provides enough energy, but obviously higher energy means a higher risk of ventilator-induced lung injury, bronchopulmonary dysplasia. You got to be very careful about the stroke volume that is provided, that theoretically should always be below 2 or 2.5 ml per kilo, although we don't even know the best amount of volume to be provided. So that is something that is very much discussed right now. And I'm not even sure that lowering the frequency in general would be the right strategy to be used. And I would suggest you also to take a look at the corner frequency, and in order to optimize the ventilation.
Okay. There's a question on, when you mentioned the first 4 hours during the presentation, how closely related is that time frame to the OI levels?
To the OI levels, what do you mean?
Well, that's the question.
OI oxygenation level? Oxygenation
yes,
index level?
I'm guessing.
Yeah, well, that's a good question, because the oxygenation index is for sure the parameter that is able to give a more comprehensive picture of the respiratory failure. But unfortunately, there is no clear relationship between the OI and the hours of postnatal age, meaning that there are some babies that can start with a very high OI and a very severe respiratory failure from the beginning, others that they can, get sicker later. The 4 or 5 hours time frame that I just mentioned is just coming from the individual patient data meta-analysis published in Lancet some years ago, and that's the best evidence that we have. But obviously, neither in the meta-analysis nor in the original trial that have been meta-analyzed, there is any OI threshold that we can consider. So difficult to say.
Thank you, Dr. De Luca. There's a question on, what's your take on the future clinical application of HFOV after the devastating results from the Oscillate trial?
Oh, I'm very much happy to answer this question, because I've been one of the critical voices against Oscillate and Oscar trial. I'm sorry to say that also, as a pediatric critical care physician, those trials have been really, really poorly designed and even poorly conducted, right? So I don't have time to go into the details, but there was a mix of co-intervention that were not being standardized at all. There was a possibility to do crossover all the time, and there was absolutely no steadiness in the ventilatory strategy provided. And even there was a very, very high volume provided in the HFO arm, which practically approached it to a conventional ventilation. Not to mention the large case mix of, primary, secondary RDS, sepsis-induced, not sepsis-induced. We don't even know how many patients actually died for non-pulmonary reasons. So I'm sorry to say that those were very pragmatic trials that actually do not provide an increased knowledge in the fields of HFOV. And this is exactly why, after these trials, in the European Society for Pediatric and Neonatal Intensive Care, we did a survey on all PICU NICUs in Europe, asking if the attitude to use HFOV would have been changed following these adult trials. And the answer was very much consistent, which kind of 97% of people answering not at all, and it's still like that in pediatric and neonatal world. Obviously not the same in the adult world, but that's another history.
All right. So there's a question on adjustable bias flow. So some ventilators have adjustable bias flow in HFOV, and some others have fixed bias flow. What are the clinical benefits of having adjustable bias flow?
That's a very good question. I'm not aware of any data about that, and it surely deserve to be studied. But it's something you must be aware of in order to be sure that you provide the mean wave pressure and the amplitude that you want to provide, particularly at very high level for the more severe cases.
Okay, there's a question on the waveforms. Is it important? Is the shape of the wave important? Is it better as a square or as a sinusoidal?
That's a very good question. I would love to know. Let's say that we suspect that this is going to have a big impact on the performances, but we do not know exactly yet if it's responsible for that, or there are other mechanisms, other technical traits that are responsible for the different performances.
Okay, we still have 10 minutes, so we're still going to continue.
5 minutes.
We're still going to continue the grilling and the question. So there's a question about the amplitude. So higher amplitude cannot be achieved without lowering the frequency in certain ventilators, especially the Draeger. Do you know why?
Yeah, that's exactly because, as I told you before, and Peter Rimmersberger group showed, these are not true oscillators. They are just flow interrupter, and they're not able to provide this big oscillation because of their technology. This is nothing new, and it was the same for the Babylog 8000.
And so still speaking on the ventilators, do you know of any data on the servo HFO?
No, I'm not aware of that, not yet.
So there's a question about the accuracy of tidal volume measurement now during conventional ventilation. Do you know of any bench studies that compare this parameter being very important to determine the compliance and the right moment to shift to HFO?
I'm not actually aware about that, but I'm sure that there should be something in the literature.
Okay. All right, so a question on the delta P, the set and the delivered. What is the item to check when there's a discrepancy between the set delta P and the delivered delta P?
But obviously, you gotta trust the delivered one.
And so is there something to do when there's a difference between both?
If there is a difference and you are absolutely sure about your flow sensor that you may want to recalibrate again or dry, then you have to increase the delta P in order to get the oscillation transmission that you actually wish. Then the thing is that you may want to have a look at your circuit, because with the right circuit, and if everything is nicely in place, you shouldn't have a big difference between what is on the ventilator screen and what has been just demanded to the machine.
Okay. There's a question on active exhalation in HFOV. Does Fabian have active exhalation in HFOV?
Yeah, absolutely. It does. It's a true oscillator.
Thank you. There's a question on water condensation problems with Fabian. Have you faced these issues? And if yes, how to solve them? Or have you heard of these issues?
We never had these issues.
If you had the issue, would you know how to fix it or how to solve it?
Well, I would say that you gotta check your humidifier and try to set it better.
Perfect. There's a question on nitric oxide, which is coming up for the first time today. Is nitric oxide in combination with HFOV easy to use with the new modern oscillators? And have you used it?
It's exactly as easy to use as it was in the Sensormatics. There is nothing really particular to do. You need your NO machine and you're good to go.
Okay. Another question, 8 more minutes of questions. Is there a difference between...
Please, I have to leave. I have another appointment.
Is there a difference between using an elbow adapter with a no elbow adapter using Fabian HFOV?
Very good question. I never thought about that. I don't think that should change anything. So yeah, I would be cool about that. I don't think it's a big deal.
Right. There's a question on respiratory mechanics and the ability of measurement of respiratory mechanics. So FOT specifically on Fabian. Do you think that this is useful?
FOT is absolutely useful, although we don't have the possibility to do that all the time because it gives you a more careful idea about lung mechanics, which otherwise is not being easy to evaluate under high frequency because there is no compliance and resistance measurement. So that's something absolutely to be done, to be considered if you have the opportunity.
There's a question on HFO in the delivery room. Have you practiced it and do you practice it?
Why the hell you should do a high frequency in the delivery room? Absolutely don't do that. I mean, the only thing you should do in the delivery room is CPAP. That's the thing to do, and try to avoid intubation as much as you can. If you have to intubate a baby, it's because of neonatal resuscitation. You can obviously ventilate him in conventional. Then we'll see with the severity of respiratory failure if he needs a HFO, but you have some hours to decide. There is no reason to use high frequency directly in the delivery room.
Awesome. So there's a question on, have there been any instances in which you had to switch from the modern HFO ventilators back to the Sensormatic device for better effectiveness?
Not with Fabian.
Okay. What's your take on NAVA in HFOV?
Well, you probably know that I'm a fan of NEVA, but obviously you know that NAVA is a thing and HFOV is another. You cannot mix the two.
And we're gonna take, I think, one more question.
That's fine.
One of the data that you've shown has suggested that none of the ventilators actually achieved oscillation transmission in an in vitro situation equal to the Sensormatics. How would you explain that?
I'm not very much concerned about that. You know, Sensormatics is very much powerful. That's for sure. But at the end of the day, you cannot even say that they were so different compared to Sensormatics. So I'm not concerned about that. Okay.
And I think we can be done because I know that you have another meeting just after this one. So thank you, Professor De Luca, for your time and for answering the grilling 47 questions of our participants today. We hope you enjoyed the webinar, and Daniele, again, thank you very much.
Okay, thank you.
And have a good evening.
Bye-bye.
Thank you.